I'm Dr. John Pittman with the Carolina Center for Integrative Medicine in Raleigh and Wilmington, North Carolina. Thank you for attending this webinar. I'm going to be talking about immunoglobulin therapy, which is a treatment for immune restoration, a treatment that I got involved with about 10 years ago as I began searching for more answers to help my patients who had chronic complex illnesses. When I first opened my office in the 1990s, I learned a little bit about nutritional therapies. I understood that patients who had deficiencies were often going to have lots of chronic symptoms. And as I understood how to replace those deficiencies, many of those people got better. And then I understood more about how the digestive system was affecting chronic health conditions and patients who had smoldering bacterial or yeast or even parasite infections in their gut might be generating toxins that were affecting the way their cell systems were working. We understood how to start working and improving the digestive health. The population of organisms, controlling overgrowth of bad bacteria, and restoring beneficial organisms to improve digestion and absorption. I then began understanding more about environmental toxins and the role that those were also playing in creating free radicals that were damaging our cells. And as a result, we knew that there was more that we had to study to get deeper, understanding that the immune system was likely a problem for these individuals. And if you have a chronic infection, then there must be something not quite working with your immune system. So I saw all these pieces starting to formulate in my mind. But it was about 1999 to 2000 when I was working with my veterinarian who was treating our cat for chronic infections that we discovered Lyme disease, that the veterinarian had been exploring Lyme disease for herself and her patients and said, "You're not going to find any human doctors that understand this. This is very well understood in the veterinary world, but I bet a lot of your chronically ill patients may have this condition." And it was through her assistance that I got involved with faculty at the veterinary school here in Raleigh and began learning more about it. And then I got involved with an organization called the International Lyme and Associated Diseases Society. That is a professional organization that trains physicians in how to work with chronic tick-borne infections. Going through those meetings really opened my eyes to what was happening with these patients. And I thought maybe now I'll understand how to deal with these infections. But I did discover that there was a subset of these people whose immune systems just were not working well enough and they weren't making enough antibodies. So you could use antimicrobial agents, but not be able to get the person's body to be able to prevent the infection from coming back. And so this really came up pretty strongly when I was at one of our International Lyme and Associated Diseases Society conferences and heard a lecture about IVIG therapy, not really knowing much about this, but realizing that many of our patients did have an immune problem and intravenous immunoglobulin therapy might be useful. So taking that information, I began trying to figure out, well, what else can I learn? Where can we get this? How can we do it? And I was fortunate to find a local pharmacy that specialized in IVIG. I was really completely in the dark about how to order this for patients, discovering that it cost a tremendous amount of money and you did have to jump through insurance hoops in order to get it paid for. That was something that most of us who do this type of practice are not used to. And so it really posed a lot of challenges, but through the help of their clinical nurse specialist, I was able to learn a lot of the details about how to document in the patient record the person's history of infections, use of recurrent antibiotics, hospitalizations, potentially steroid use, all of these details that need to be in their medical record to make your case that this person might be a candidate for this treatment. In addition, I learned how to do laboratory testing to get the objective documentation to show that these individuals have a dysfunctional immune system and that they therefore would be a candidate for this treatment. And it was through that process that we were able to actually get a lot of people approved for this treatment, and it has really been a game changer for many of our folks over the years. So I wanted to do this webinar to really share with everybody what I've learned about this. This is directed potentially toward a medical audience because there are many doctors that do not understand this treatment. They don't understand that how to do the documentation, how to get their patients approved, how to work with it. You know, most of us don't know about it because they don't teach it to you unless you're specializing in things like immunology, rheumatology, neurology. It is used for those very subspecialty areas. And so, unless you really search for the help, you really don't find it. So, getting this introduction through ILADS and then connecting with a fantastic pharmacy that was able to teach this to me has really helped us a lot. And I want to share this with other physicians so that they can bring this into their treatment as well. And so I'm going to bring up a presentation that I have, and we'll be going through this. And thing to note here, the title is about using immunoglobulin therapy in chronic complex illnesses. And it's really about the chicken and the egg, and you'll see what I'm talking about in just a minute. But this is mostly about being able to understand these various topics that we're going to cover today. We're going to be talking about the history of immunoglobulin therapy, how it's produced, how it came about, different formulations, ways of administration, and how it might be particularly useful in the practice of a patient who treats chronic complex illnesses, particularly tick-borne infections. I'm going to focus particularly for physicians on how to get your patients approved for IgG therapy, what type of medical record documentation and laboratory documentation is needing, how you dose and administer this, how you order it from the pharmacy and then monitor it, and how you change doses and manage any side effects, and ultimately what is your long-term prognosis. So as we said earlier, IgG therapy comes from blood donations from which you have extracted the antibodies. Immunoglobulins are antibodies, and they come with a broad set of antibodies to a variety of different bacterial and viral agents. So administering this to a patient who has immune deficiency is putting back in all these fighters to help them deal with whatever microbial situation they maybe have. So this can be an extremely helpful and effective tool for patients who work with chronic infections. So here's this chicken or egg concept. One thing that we noticed early on is that we have patients who have come to us because they have a chronic infection, and then we discover that they have these terrible immune deficiencies. So the question now is that these patients get the chronic infection because their immunoglobulins, their antibodies, were low. On the other hand, could it be that their infection was like leaving your car lights on and run the battery down, and that dragged the immunoglobulin levels down? And so ultimately, it's an either or. You can have one start the other, but it doesn't really matter. You have to address the situation with that individual. And when we look at the structure of IVIG, this Y state structure is very interesting because you have a constant region at the base, but the really interesting part is the variable region. Those are the areas that become sensitized to specific antigens, to specific bacteria or proteins from other organisms, and learn how to go after them. So that's the little jaws of this critter that's going to go after our infections. So when we look at immunoglobulins in the bloodstream, we have a variety of these. What I'm talking mostly about right now is immunoglobulin G, which makes up about 75% of the immunoglobulins in the blood. But IgM is another important one, although smaller in quantity. That is the antibody that gets on the scene in an early phase of an infection. It's bringing the National Guard in, so you get immediate help while IgG takes a little longer to build up, but it is a more robust, more effective antibody and can ultimately control the infection more effectively and even hang around over a longer period of time to provide future protection. IgA is an antibody found in mucous membranes and may have some impacts on gut infections, but it may be very low in some of our patients, and you've got to be aware of that because of potential allergic responses. So when we are looking at IgG, we're looking at the totality of all the immunoglobulin G levels, but there are actually subclasses, and those have particular importance. So in the case of subclass 1 and 2, those are ascribed to have bacterial activity, while subclass 3 has fungal activity and 4 parasite activity. An interesting note about number 4 is that because it can also be identified in patients with autoimmune conditions. So you may have elevated levels indicating there's quite a lot of immune activation. Another important point to make about subclasses is that when physicians are ordering these from the labs, there is a difference between Quest and LabCorp, the two major national companies. And you can see here that the bottom for Quest for subclass 2, the low end of the normal range, is 241, while LabCorp goes all the way down to 130 rather. And so that means that that cutoff is going to miss people who really have low subclass 2 if you're relying on a LabCorp test. So since the purpose of testing is to get documentation to help you with your medical record argument that this individual could benefit from IgG therapy, and you have the documentation and the history and all the other details, you want good laboratory records that are going to help you, and a LabCorp is not going to help you. So it has to be done through Quest. In terms of how IVIG is manufactured, this can come from as many as 10,000 different donors from which the immunoglobulins are extracted. They are then put through processes to deactivate viruses to make sure they're not going to transmit any type of infections. And these different processes are proprietary in that different manufacturers have different ways they've developed it, whether it's through solvents, pasteurization, ultraviolet, or radiation filtration. These all have are very, very effective, and they really remove virtually all contaminants and pathogens. And so when we're looking at the use of immunoglobulin therapy in a typical practice for a tick-borne infection a clinic, we are really focusing mostly on those individuals who have immune deficiency. And the overall term for this is common variable immune deficiency. And this includes the categories shown here, which is low total IgG, hypogammaglobulinemia, selective immune deficiency, and those are the subclasses. Humoral deficiency, probably one of the most important ones, because that is actually an inability of your immune system to respond to a stimulus, to respond to something that ought to turn on your immune system. And specifically, this is the pneumonia vaccine. So this is the way your body is taught to fight an infection. Now, there are other uses for intravenous immunoglobulin, and these do apply in tick-borne infection practices, although they're not quite as common. And these are different types of neuropathies, myopathies, and autoimmune conditions. And it's very important that TBI physicians are conscious of these indications and are screening for them, because you may find individuals who really do need this treatment for these uses. In fact, in the case of the autoimmune conditions, particularly the encephalitis, this is actually an emergency. This is as close as you can get to being in the intensive care unit in your line practice. So when we look at the bottom line here, our goal is to be able to get insurance to pay for this treatment. It is too expensive a treatment for people to pay out of pocket. And so the way that we've generally found we can get this covered the easiest is with the diagnosis of humoral deficiency. That is, again, the inability to mount an adequate antibody response. And the result is you keep recurrent infections and you have to have repeated courses of antibiotics. And so we certainly need to be assessing for that and looking to find whether or not patients have low or low normal total IgG in subclasses. And occasionally they really won't have those numbers that are that low. But if there are other parts of their history that make you suspicious, you do need to look for a humoral deficiency. And so this process involves first taking a very detailed medical history. When we see our patients for the first time, we have got to be Sherlock Holmes and ask them a million questions. And we've got to go through a lot of detailed questions about their history of infections, antibiotic use, whether they've been hospitalized, needed steroids. Particularly for upper respiratory things like pneumonia and sinusitis, and so when you do see those types of things in a history, you've got a lot of suspicion that they may have a problem with immune response. And certainly tick-borne infections are not off limits in any way. That is a chronic infection and needs to be noted in the record. Of course, one of the most important things for us to note is, has this person had the pneumonia vaccine? Had they had the Pneumovax? So this is a very common vaccine given to older individuals to prevent streptococcal pneumonia. And most people over 60 are getting it. So if you've got a patient who says, yeah, if I got that a year or two ago, then you're definitely going to want to see whether or not they have those antibodies to that vaccine. And so everybody should get baseline screening for streptococcal antibodies, whether they've had the vaccine or not. And so when we look at these streptococcal antibodies, the bottom line is, are they there or they aren't? Now, somebody who's never had the vaccine, I would not expect to see very many of these antibodies. There are 14 of them, and sometimes you might see one or two that are a little high from some cross reactivity, but for the most part, they would all be low, generally less than 0.3. And so if somebody has had the vaccine, you would hope to see that their antibody levels are above 1.2 micrograms per milliliter. And if there are 14 of them, I would like to try to see that at least 6 or 8 of them are present. If you do see that, then that person has had a fairly decent response to their vaccine. But if not, then you need to do a little bit more digging. And so what we need to do then is to explore whether or not they may have these findings. And again, we're going to bring the patient back in, we're going to go over their initial labs, and we're going to talk to them about these lab findings. And we're going to say, look, you've got some iffy looking immune markers. You've told me some concerning things about infections. You got that pneumonia vaccine about 3 years ago, and you have no antibodies left to the vaccine. So it doesn't look like you're making antibodies very well. So you start talking to your patient early on about the potential for IgG therapy to be considered, that we want to carry them through a workup for this. They don't necessarily need to make a decision right then to begin it. You need to get it approved before you really get into that a whole lot. So they just need to be receptive to the process. And so the first step we're going to need to do then is to do the streptococcal vaccine challenge. And that means that the person will need to go and get that vaccination and us find out whether or not it works. And we need to particularly make notes in the prescription that this is for immunological testing, especially if it's a younger person, to be sure that they'll give it to them. And that is given at your regular pharmacy. So they'll do it with the doctor's order. And it is very important that the physician order this as the Pneumovax 23, a specific brand, and not the conjugate vaccine, which is the Prevnar. The reason being is the Pneumovax 23, the polysaccharide form, is the basic pneumonia vaccine for which the studies were developed, and you're meeting criteria if you use that one. So we give them the vaccine, and then we're going to wait about 4 to 6 weeks and check those antibody levels. And we need to see that at least 8 out of or 10 of them have gone up. They need to go up actually fourfold. And if they do, great, you've got a good immune response. This is not about, this is about saying, hey, you do have a good immune response. Although if they don't do it, then they're looking like they may be a candidate for the IgG therapy. So if they don't really see much of a good response, you may be ready then to send it an order and see if you can get it approved. But sometimes you're going to need to recheck it a couple of months later and see if maybe it was just delayed. It took a little bit longer for it to go up. Or if it did go up, it nosedived. And we've seen some people, we thought, wow, that looks like a good immune response to the vaccine. And it ought to last 10 years. And here you are 4 or 5 months later, and it's not there. So you still then be able to figure out that this person has this humoral deficiency problem. And so one of the things that we try to do to make it very clear visually in the approval process with insurance is to use an Excel spreadsheet where we can document the antibody levels, the subclasses, and just show right there, in columns what each lab test has shown. And so you can see here on the left side where we have the antibody names, the numbers there, and then the IgG below. And we have our baseline levels here from back in March of 22. And you can certainly see the majority of those are very low. The person then got the vaccine and got a post-vaccine test about 4 weeks later, and 6 of them did not go up fourfold. So that's not a super vigorous response to the vaccine, but it may be just it's delayed. So we're just going to have to wait. And part of getting IVIG for your patients is that it is going to take some time. It's about developing the story and developing the documentation, and that just doesn't happen overnight. So look here, it's like 6 months later before we were really able to get another lab that showed that now we have failed 9 out of those 14 titers. This person did get approved for IVIG based on failing this pneumonia vaccine. And you can also see there that the IgG subclass 2 has been low both of these times. Again, that is with Quest. So when it comes to actually using diagnosis codes, that's the language of insurance companies, and we do have to use the correct terms that convey what the labs are showing. And so the most common codes that we use first is because of this failure to the antibody to the Pneumovax, and that's D80.9. D80.3 is the selective subclass deficiency, and then D80.1 is for total IgG deficiency. You would think that total IgG deficiency would be a good covered cause for IVIG. It turns out that they want that number to be so much lower than even the bottom of normal. It's harder to get it approved for just that one. You need the other codes in there to ensure you get it. So when you're doing your intake on your patients, you've also got to include in your questions and review of system a very thorough neurologic and psychiatric history, as well as rheumatological, autoimmune joints, muscles, and so forth. This is to find indications of these other potential uses for IgG therapy. Some blood testing that might be useful if you think there may be some type of tissue breakdown, muscle damage, creatine kinase. If you think there's some brain injury, antibody autoimmune effect, the GAD65 can help. And probably the best panel, if you do suspect some type of autoimmune brain inflammation, is the Cunningham panel. And really that's another lecture that I could be getting into on all of these aspects of neurologic inflammatory conditions. So just to hit the main ones here, is the chronic inflammatory demyelinating polyneuropathy. So that is an autoimmune condition where you get damaged peripheral nerves, and it can be identified with certain types of tests that are done by neurologists and include nerve conduction studies, as well as other types of biopsies where you're actually looking for nerve, where there's these degeneration of sensory nerves. And these can be found in a lot of our very sick patients, and they may have been missed by regular physicians. And even people who come in with ALS, a really horrendous degenerative condition for the neurologic system, and they may wind up having the CIDP as well. And so the autoimmune encephalitis is probably one of the scariest ones that you see. And this comes from the production of antibodies that actually are attacking the brain, literally going after brain tissue, the receptors, the places where the neurotransmitters are working, and it causes destruction of healthy neurons, and it can cause swelling of the brain and cause a range of symptoms, many of which are psychiatric. Some of these can be very disturbing, and particularly when you get into psychosis. You are dealing with sometimes emergency situations and hospitalizations coming from these types of conditions. Seizure disorders, very common in many of our patients, very challenging to address. And one of the original diagnoses for this was called PANDAS, which is a type of neurologic syndrome first identified in children, meaning pediatric acute onset neurologic syndrome related to strep. So this is where strep infections would trigger these types of ongoing encephalitis conditions. And we know that this is broader than just strep. And so a general term for this has been PANS, and that does include Lyme as a trigger for it. And so when you start looking at considering the treatment, so now we've worked our way through the process. We've got our documentation, we've got our labs, we've talked to the patient that this might be something we want to do, but we've got to look first. If we're going to order it, is there some reason we can't? And a person who's got really severe bad kidney function, going to really think twice about that. The IgA deficiencies may be an issue. Bad cardiovascular disease isn't mentioned here, but that might be a reason to be very careful. But there really are no absolute contraindications, and this is really a patient to by patient plan. So at that point, if we think we may be interested in this, that the bottom line is, can we move forward and get it for the patient? And so from the patient standpoint, they've got to be willing to do several things. First, they've got to be able to do the vaccine challenge. If they don't want to do that, we're not going to be able to document the problem with the immune response, and they're just not going to get it. If we think this is a peripheral neuropathy problem, then they've got to undergo either the skin biopsy or the EMG, nerve conduction studies. They don't want to do that, we're not going to get it for them. And ultimately, the primary issue that may block them is if they just simply do not want to take anything that's derived from blood products. And you do have some people that have maybe religious reasons for this, or more suspicious of potential problems with the blood supply. And again, we can talk to them about the risk and benefits from that perspective. But if this is a no starter, then don't waste your breath, don't go through all the process. But ultimately, the biggest barrier to treatment is whether insurance will pay for it. And here again, you've got different companies that have different approaches to it, but if you've got good documentation, nearly all cases you can get it approved. So then the next question you have with your patient to discuss is, how are we going to administer it? So historically, IVIG has been given as an intravenous infusion. Of course, that is convenient for people who need more assistance, folks who have good veins. That would be certainly a prerequisite. And the nice thing there is home health nurse comes to your house, gives the infusion about every 4 weeks or so, and it takes maybe 3 to 4 hours. So it does take a chunk of time. It takes having something in your schedule, but it is certainly the way historically it's been done. And it's the only way to do high dose IVIG, which is required for the neuropathies as opposed to just the immune restoration. In more recent years, there has been developed a subcutaneous form of immunoglobulin therapy. And that has the advantage of being able to be self-administered once the patient has been taught by the home health nurse And but it does have to be given on a weekly basis. You can't put as much in if you're putting it into the tissue, usually in your abdomen, maybe your thigh. And it goes in over maybe 30 or 45 minutes and makes kind of a little golf ball swollen area, and then it's absorbed into the skin. So this works really great for people who don't have good veins, but they do have some padding on their skin. Somebody who's very thin, minimal subcutaneous tissue, they're probably not going to tolerate the sub-Q very well. They probably need to do the IV. People who are really, really busy, their work schedule is crazy, they need flexibility in their timing. Sub-Q is going to be great for them. So this is going to have to be a figure it out with the patient at the time. And so now we are going to make this decision about can we get going with it? We're ready to order it. We've decided we're going to do either IV or sub-Q. We're going to send the order to the pharmacy. And something that we've learned here is that because there are no generic forms of these therapies, it's all dependent on insurance companies' formulary. And that means this insurance company needs to use this product. They want to use this one. And so you don't know that. And it's going to have to be something communicated between the pharmacy and the insurance company. So we simply write the order as IVIG or sub-QIG, pharmacy to determine, and then that gets sent out and the insurance tells them what to use. We also have to indicate the concentration. Generally, more dilute products work better in an IV setting. Hydration is important in IVIG. It is a big protein substance, so you don't want to be too much stress on the kidneys. So we come up with the concentration, typically 10%. Dose range is 0.4 to 0.6 grams per kilo. And we generally start kind of somewhere right there in the middle at 0.5. And we'll see where that takes us based on clinical response and laboratory testing. We mostly do this about every 4 weeks if we're going to be doing for IV. If it's going to be sub-Q, it will be once a week. Neuropathies and myopathies, autoimmune, are going to have to be a higher dose, and they're given more frequently. And what you're looking for is patients who will say, well, I could tell that I got some benefits from this, but I could tell it was fizzling out toward the end of the 3 weeks. And that may mean that you need a higher dose to last you longer. It may mean that you're using up those antibodies faster. They're really working hard to try to deal with these organisms, and they're just going away too quickly. And you may actually need the treatment every 3 weeks. If we're going to order the sub-Q, it's going to be a little more concentrated. 20% is more typical. There's a little bit difference in the dosing calculation that you can see in order to get your weekly dose, and it's a little bit more precise in terms of the concentrations. And so weekly dosing generally works well. You're assessing the same thing. Does the person feel a boost after they're in treatment? And then toward maybe the 5th day, it's coming down. And that's going to help you figure out what you're going to be doing. I mentioned that IVIG and autoimmune encephalitis is different. It is a big dose. This is an emergency treatment. You're going to be giving a high dose over 4 days. Now, the biggest problem is that most insurance companies are going to require a steroid trial first, meaning that you're trying a very powerful anti-inflammatory to see if you can put this fire out that's in the brain, and see if that may help that patient. And if there is no documented improvement as a result of that, then you likely will be able to get the IVIG. And you actually assess this fairly soon and may even repeat it earlier than you might in the other treatment. So really what we're focusing on then. So let's say we've submitted all of this to the insurance company, we gave them the orders, and it got approved. Now we're ready to engage. Now is the time that we need to have a brief visit with the patient and say, this is just focusing on this therapy. Let's go over all the risk and benefits, the adverse reactions, things you need to know about how to make this infusion optimal for you. and make sure you understand the risk and sign a consent form. And once that's done, the patient knows what to expect, how we're going to monitor it. Then we can let the pharmacy know that to start treatment. So we do want to talk to the patient about some of the more common, although mild side effects that might happen. And really the most common is headache. Patients who will just have a really pressure type headache all over the head. It's really swelling. And it's those blood vessels in the brain that swell and ooze out some fluid into the brain tissue. It's almost like a migraine. And in fact, it can be improved by consuming some caffeine starting the day before, day of, and day after the IVIG or the sub-QIG infusion. That can often go a long way to reduce headache. Hydrating a lot. We want people to drink plenty of water. Fatigue is another common symptom, and that is one that often is transient. We're also seeing some things here about nausea, fever, flushing, blood pressure changes. So those are more often common. Patients who have cardiac issues, you need to be thinking about their fluid status. And so other things to be thinking about would be whether there's any type of vein irritation, dehydration, nausea, vomiting, fever and chills. I'll talk a little bit more about that. Again, rare that we see any of these severe things like thrombosis or hemolysis, kidney failure, but it is something that you have to inform the patient about in their consent form. So the hydration is the most important steps you can do to minimize side effects, and generally consuming half your body weight in ounces of water per day, days before, and just keep it going. That is the best way to hydrate well. And again, using the caffeine can make a big difference also. And then in terms of blood testing, there is value to testing and monitoring blood values, although everything is not determined by that. You are shooting for a certain level of IgG in the bloodstream at the trough point. The trough would be 4 weeks after your last infusion, right before your next one, if you're doing a 4-week IV. If it's a weekly sub-Q, it's the day of or the day before the weekly sub-Q infusion. So you're seeing what it is at the bottom. And the goal is that it at least is good enough to give you what you're shooting for therapeutically. If not, then you need to raise the dose. If the level is way too high, you might want to back off. But it really boils down to what is the patient response and how are they doing. And so we try to give ideas about what is going to be happening over the long term here. And ultimately, when I'm having a conversation with patients about this treatment, I really encourage them to do this for a year, to stick it out long enough, because you don't see the effects right away. You may see actually some adverse effects early on, and that may be actually due to the immune system turning on. So if you've got a smoldering infection and your immune system starts waking up, it's going to go out there and begin to shoot up all the bad guys, and you're going to have a bloody battlefield with all this trash that is going to trigger more of an inflammatory response. This represents what is called a Herxheimer reaction. We think of it as a die-off reaction, and in this case, it's coming from the immune response that is able to kill these organisms. So the Herxheimer response is real. It can cause fatigue, body aches, feeling like you have the flu. This may happen for the first few treatments until everything starts to calm down. And then patients begin to start feeling a very positive response after treatment that continues to build with each month. And so we really want to encourage people to give the time to see what this can do. At the end of that year, you've got various things to consider and discuss with your patients. And if you've got somebody that has really come a long way, this treatment has allowed you to go further into treating their underlying infection, maybe get that completely stabilized. If these people are really in good shape and they They say, you know, I'm tired of this. It's taking so much time. I'd really like to have a little break. It's perfectly okay to do that. And some of them absolutely do great. You have really recovered the immune system. They've been able to keep the infection under control, and they are gliding down a nice little maintenance path. You see those also who do very well for a period of time, but they start hitting some turbulence and they may begin to slide back and need it as well. But you have other people who may be very improved at that year, but they're not recovered. They're probably not a good candidate to discontinue. And you have patients who really may never recover their function, and probably it had always been poor. And if you've got a person with that history that I was talking about that's been in the revolving door of infections and antibiotics, I'm very concerned that they're going to always need this potentially on an ongoing basis, especially if their labs were really, really low. And so, in the long run, what we're trying to do is get the best results for those patients who've been the sickest the longest time, who have had the hardest time making response to antimicrobial therapies alone. That really is a subclass in my practice and in the practice of many of my colleagues for which this treatment is so important. But if you have not been able to get rid of the dormant infections, these people may still need ongoing therapy. And a lot of this does take having clear goals that you work out with your patients and even work in with concert with your pharmacy staff. And it's important to recognize that for healthcare providers, a specialty IVIG pharmacy is going to be critically important to helping you understand your patients better, uh, and be a part of the healthcare team, help you figure out this therapy, monitor the patients, speak to them when there are problems, give advice on lab testing and adjusting the doses. All of those are very important, and you need somebody that's more like a local pharmacy for that. The big giant companies, they really don't have the type of customer service that we're looking for here, the hands-on care that is needed. So finding one that is really patient focused. Two individuals at this pharmacy that are critical: your account representative, who ideally needs to be a healthcare professional and to have had actual clinical experience, substantial direct working with these types of patients and with this treatment. They need to be tuned in to our patient population. They need to know what our trends are, where what we are dealing with, and understand the uniqueness of how to get our patients approved and managed in this treatment. So this is an invaluable person, and the pharmacist is equally so. This person also needs to have a rich history of working with IVIG and sub-Q and be able to assist in that clinical decision making, working hand in hand with the providers in caring for their patients. And so the key thing, a part of this relationship with the pharmacy, is giving them access to your medical records, which as a covered entity with HIPAA, they are allowed, and you can have a business associate agreement that allows individuals who have access to your patient records for medical care and continuity of care. And that way they can get the records, they can provide them to the insurance company. This is the easiest way to transmit all this data. And so, particularly if you have an electronic system, it works great. And so basically, what we're trying to do is figure out what to do for these people who've been stuck, to find some way to move past their chronic infection. And what we realize is that there are a lot of patients who could benefit from this treatment who have been marginally evaluated. Uh, Physicians may have been scared off by it, they just did not understand it well enough. I am hoping that this video is going to help people recognize how to do this, get this in the hands of more physicians and more patients. It really can be life altering for these types of people. And it is important for our practitioners and our members of ILADS particularly to understand the value of this treatment and know how to implement it in their practice. So I appreciate very much everybody seeing this video with me. I've got some references here as well. This will be posted on YouTube and it will be a link on our website with this beautiful picture of the mountains. So thank you all for joining me today, and I hope this has been helpful for you. Bye bye.